So the presence of TP53 disruptions in Waldenström macroglobulinemia is the subject of fierce debate these days. This is something that's been an established trigger point for use of different agents in the setting of chronic lymphocytic leukemia, CLL. But for various reasons, it's been less established in the WM setting up till now. Possibly there are newer techniques for identifying this disruption. And I have to say the methods for picking up these mutations are still subject to variability in terms of sensitivity, etc. So bearing this in mind, if there is a TP53 mutation in a patient with WM, are we ready to use the same kind of criteria for treatment selection in WM compared to CLL? We did have a debate of this at the International WM workshop, and I think there is still uncertainty. My view is that we're not quite ready for this yet. There's no doubt that TP53 mutations and deletions, they're relatively rare in early stage WM, but they increase in frequency as the disease progresses, or indeed, if there's transformation to more aggressive disease. So what I would say from that point of view is it is worth looking for these mutations, preferably at baseline, but certainly at relapse, to see if they are joining in the clinical picture and the biological picture. The next thing to say is that there's a lot of investigation of these pathways and therapeutic strategies, but no standard targeted therapies have yet been established for TP53 mutated WM. So in my view, it's still a prognostic marker, but not a marker to define treatment decisions. I think some of the questions that arise are, for example, based on the CLL experience, there is a poorer response to chemotherapy-based regimens in CLL when there is a TP53 mutation. So should we avoid chemotherapy in patients with WM? For example, bendamustine and rituximab. Now, whilst I say that in general, I do not think this should be a clear-cut decision-making factor, in our own practice, we do think hard about this in someone who's TP53 mutated, because we do expect them to have more resistant disease, and the traditional approach of chemotherapy, and perhaps in some cases proceeding to high-dose chemotherapy in an autologous stem cell transplant, is something to be very mindful of as to whether that's the right thing to do. But equally, I'm not 100% sure that we can literally reach for a BTK inhibitor and feel that this is the right thing to do, because that is a decision that commits the patient to long-term continuous therapy. So I believe at the moment there are limited data on targeted therapies for TP53 mutated WM. And I think that it's most likely associated with a poor prognosis, but data are not yet robust enough, and we definitely need more clinical trials and additional research to define how TP53 mutations influence therapy selection.